All right, everyone. Thanks for sticking around. And this is the highlight of our conference. It's my great pleasure to introduce my dear friend, Dr. Adrienne Kovacs, as the keynote speaker for this conference. Dr. Kovacs is a Canadian psychologist who has worked as a clinician, researcher, and educator in the field of adult congenital heart disease for over 20 years now. She is the past president of the International Society of ACHD, and she was the first non-physician to hold this position, which is a great honor. Previously, she was professor of medicine in the Division of Cardiovascular Medicine at Oregon Health State University. She has chaired the 2022 American Heart Association Scientific Statement on Psychological Outcomes and Interventions for Individuals with Congenital Heart Disease, and was a co-author on the 2011 and 2022 scientific statements on transition in congenital heart disease. Last year, she launched Equilibria Psychological Health with dual focus on psychological well-being of both adults with heart disease as well as healthcare professionals. Dr. Kovacs, thank you.
Thank you for that introduction. I'm going to screen here. Well, good morning, everyone. It's a pleasure to be here with you today. I'm actually doing this from Montreal. So although I'm a Canadian and I primarily live in Toronto, I'm in Montreal for the summer. So bonjour, everyone. As I was getting ready for this, first of all, I'd like to thank Arvind and Andrew for the invitation. And I was looking back and I realized that the first presentation that I gave on transition was in 2007. So Gary Webb had invited me to speak at an ACHD conference in Philadelphia. And I was thinking about how my own perspectives on transition have changed since that time. So I think many of us who have been working in this field for a long time will maybe describe a transition to transition, if you will. I practiced in Toronto for 11 years. And as Beverly described, I worked really closely with the Good to Go program, the hospital-wide transition program at Sick Kids that actually is no longer. And I worked closely with Miriam Kaufman. And in Toronto, as in many places in Canada, we actually have mandatory transfer at the age of 18. I also worked for almost 6 years in Portland, Oregon, where we had a flexible age of transfer. And in both places, we established a transition task force comprised of both pediatric and adult providers. And even now, although I've left formal academia, I'm still engaged in research focused on transition. So right now, most recently, we've been developed and have been evaluating an app that we developed for transitioning youth, both with brain-based disabilities and congenital heart disease. And I mention this because transition has been an issue very close to my heart for over 15 years. And I have no disclosures. All right, so to begin, when I was thinking about putting this presentation together, I really hoped that attendees would leave with improved knowledge and practical skills. So I hope that by the end, people will be better able to describe why we have a collective responsibility to improve the transition of youth with special healthcare needs from pediatric to adult care, and really using congenital heart disease only as an example. And also, I hope that people are better able to apply strategies to improve transition experiences and outcomes, and really within a team-based approach. And that's one of the things that I'll emphasize today. So I think that transition is a very important opportunity to improve the lives of individuals born with congenital heart disease and other special healthcare needs. And I just wanted to include one slide because I realize that not everyone will be familiar necessarily with congenital heart disease. So this is a figure taken from a scientific statement that we published last year looking at psychological outcomes and interventions for congenital heart disease. And I use this figure to really convey the journey that people with congenital heart disease face. So there are many potential psychosocial stressors that are common and really understandable along the timeline, and transition is just one of them. So even beginning in the prenatal period, so oftentimes there's an increasing proportion of people who are diagnosed even before they're born. They can face challenges in the intensive care units, early family life as they're developing their identity, education, early peer interactions, And transition is something right in the middle there. And this is something that affects every one of our patients. So not everybody will have difficulties with education. Not everybody will have traumatic healthcare experiences, but all of our patients that reach adulthood will have some form of transition. And if we follow along this to the end, as James mentioned earlier when sharing his patient experience, there absolutely is a transition to older age also. And I was thinking as James spoke, and I reflected that many of the patients that I've worked with, they have described living with congenital heart disease as a part-time job for which they never applied, but they say it takes up a lot of effort. And this part-time job does not pay them, and that they actually have to pay financially with time, other resources to keep this part-time job. As mentioned earlier, transition is a process and transfer is an event, and sometimes they're used incorrectly interchangeably. Just going back to this definition that I think Andrew shared earlier, transition is a purposeful, planned process that addresses the medical, psychosocial, educational, vocational needs of adolescents and young adults with chronic physical and medical conditions as they move from child-centered to adult-oriented healthcare systems. And I really see two distinct aims of transition. The first is continuity of optimal healthcare across the lifespan. And what that means is that we avoid lapses in care, or this expression that we often use, loss to follow-up. I prefer the term lapses in care, by the way. And this isn't easy because this depends upon a patient being informed about the importance of lifelong healthcare. It means they agree that it's important and worth any discomfort or inconveniences, and that they are able to access it. And the second aim is that we help youth develop the knowledge and self-management skills to assume maximal responsibility for healthcare management and live as full and independent lives as possible. And I emphasize words like maximal and as possible here for a few reasons. I think this is one area that I've shifted my thinking on transition over the past several years. I think when I began, I thought, okay, by the age of 18, we got to get everybody ready to do things on their own. And I think that we now realize that it's an extended process. But also, particularly if we're thinking about health conditions like congenital heart disease, where there's an increased risk of neurodevelopmental deficits, delays, and disabilities, not everybody will be able to assume full responsibility in adulthood. So the goal is to work with each individual patient and figure out for them as an individual, what is the maximal responsibility that we can help them develop so that they have as much influence over decision-making and responsibility in their lives as is possible for them. I very much consider this as a timeline approach. And in the discussion earlier, I think there was a question about when we begin transition. So I see this really as an extended process. So beginning in childhood, even at birth, parents can be prepared for their children with congenital heart disease or another pediatric onset health condition to become adults with that condition. So I like when I hear parents asking questions about what's this going to be like for my child when they grow up. Beginning by 12 to 13 years of age, patients can be helped to gradually develop knowledge and self-management skills. With regard to transfer, guidelines recommend a flexible age of transfer, ideally between 18 and 21. So the 22 years in the transplant program that was described really well earlier, that sounds like a fantastic program, very reasonable. Again, it's different in Canada. So most provinces at the age of 18, you cannot be admitted or seen in a pediatric hospital. And then there's this idea of emerging adulthood. And what this means is between 18 and 25 years, these knowledge and self-management skills continue to develop. And in emerging adulthood, we really see this emphasis on decision-making and responsibility. And what this means is that we really need to think about collaboration of pediatric and adult clinicians. So transition isn't something that we can allocate solely to the pediatric setting. Well, how are we doing so far? So how far have we come in the 16 years since I first gave a presentation? Well, Going back even farther, here are some key documents that were released about 20 years ago. So something from the a nice summary consensus statement from the American Academy of Pediatrics from 2002. There was a statement I referenced earlier from Society of Adolescent Medicine from 2003. We also had a Canadian consensus statement in 2007. And so 10 years, almost 10 years after publishing the first document, the American Academy of Pediatrics released a follow-up statement. And they noted that after nearly a decade of effort, widespread implementation of health transition supports as a basic standard of high quality care has not been realized. Not much happened in that decade. Well, what about congenital heart disease? Are we any better? Well, in 2011, we published the first scientific statement from the American Heart Association focused on best practices in managing transition in congenital heart disease. And at that time we wrote, we acknowledge that the development of ideal transition programs is a laudable goal that may not be achievable in the current healthcare environment. And I will say that as an author on that document, I wish we had not included that statement. We gave everyone an easy out. We said, this would be good to do, but maybe it won't be realistic. If you know anything, I would say that in the past dozen years, the healthcare environment certainly has not become more amenable to investment in transition. And just last year, we published a follow-up statement. So again, here, advances in managing transition to adulthood for adolescents with congenital heart disease. And we noted that since the 2011 scientific statement was published, efforts have been made to include transition programming as part of pediatric congenital heart disease programs, but there remain significant challenges to successful implementation. We have not succeeded. So we have great documents and statements explaining what we do, but I think we've earned a failing grade in most places when it comes to the implementation. So let's talk a little bit about lessons that we've learned from congenital heart disease. So first of all, when we think about that initial goal of retention in care, this study was published, 10 years ago now, and it's the Heart ACHD trial. So Health, Education, and Access Research Trial. They enrolled almost 1,000 patients from 12 American adult congenital heart disease centers, and they were recruited at their initial visit in the adult setting. And they completed surveys about gaps and barriers to care. And they found that 42% reported gaps in care of 3 years or longer, including over a quarter with severe forms of congenital heart disease. And the median age at first gap was right about 20 years. So when do these lapses begin? Because we often will focus, as that last study showed, that we really need to focus on retention and care around the time of transfer. So here's a study, and it is a great study, and it's an old one, but we still refer back to this, and it's from the Quebec Provincial Physicians Claims Database. And they enrolled individuals born in 1983 with congenital heart disease diagnosed before the age of 6 and who were alive 22 years later. And they investigated outpatient cardiac follow-up as well as any contact with the healthcare system. And they found that only 39% had cardiology follow-up after turning 18, but 93% did have some contact with the healthcare system. So for most of these people, they were not absent from healthcare altogether. And I should mention that this project was led by Andrew Mackey, and he was a fellow in Montreal at the time. He's now in Edmonton. And I would say that he puts out some of the greatest, really strong research in terms of transition interventions in congenital heart disease. And he and I still are very close collaborators. And this is the interesting figure from this research from the Quebec Physicians Claims Database. So they started with 643 patients who were diagnosed with congenital heart disease by a cardiologist under the age of 6. And then we can go across age categories. So by the time they were 6 to 12, fewer than 2/3 were seen by a cardiologist. So the pink refers to attrition, people who were lost in that age category and never seen again. The yellow refers to people who were absent in that age category but appeared at a later one. By 13 to 17, fewer than half of the people, these patients, were seen by a cardiologist. And then, as mentioned earlier, that decreased to 39% in the 18 to 22 category. And the important takeaway message is this: if we wait until patients are 16 or 17 to start talking to them about the importance of lifelong care, we will be too late. So why do patients say that they have these lapses in care when we ask them? They describe a variety of reasons, including that they're feeling well, they didn't know follow-up was required, some of them were specifically told that follow-up was not required, they don't know where to go, they were discharged from the pediatric hospital without identified adult congenital heart disease clinics. Some of them have a complete absence from medical care. There's a lack of insurance or inadequate insurance. And some people are absent from care due to psychological reasons. So they are fearful of receiving bad news. So we know that retention in care is a problem in congenital heart disease. Well, what about knowledge gaps? So just to share a couple of studies with you. This first one is from 2010. And this was done this is in the Netherlands. And they asked several questions. So, and we can see here that only 45% could describe the name of their heart defect. So less than 1 in 2 patients could actually describe the name of their defect. And still fewer knew the importance of follow-up, what to do if they have side effects for the medication, or what endocarditis is. And this study was just published in 2023. And so in this study here, this was done in London, England, and they did an intervention. Actually, they studied people who had attended transition clinics, and they enrolled almost 600 people. And the 3 bars on the left are patients without learning disabilities, and the 3 bars on the right are for people with learning disabilities. And they call it Ready, Steady, Go. And just those are just the first, second, and third clinic visits. And if we look at the Ready on the left without learning disability, so at baseline, when they're about, I think it's like 15 or 16 years old, we can see that only 40% of the people were fully able to name their heart condition. So they also asked them questions about describing what they had and explaining it. And that dropped to, 20% were fully able, 40% unable, and that dropped to about 10% who were unable at follow-up visits, so through this intervention. But again, most people were not able to even name their health condition, and far fewer people with learning disabilities. So it began at just over 60% were unable. And I mention this because this is something over 12 years that it's still an ongoing issue. So despite efforts that we've been implementing to improve patient knowledge and self-management skills, we haven't really realized, I would say, meaningful change. So let's switch gears now and talk about strategies to improve transition experiences and outcomes within a team-based approach. We have excellent guidelines from GOT Transition that was shared earlier. We also have transition documents from NICE in the UK, Canada in the middle, Australia with the beautiful documents on the right. And I would argue that it's really time to move from guidelines to implementation. And when we think of the key stakeholders, as Andrew mentioned in his introductory remarks, the patient absolutely is centered here. So we have the patient in the middle who's expected to, or we help to support them to develop and negotiate independence and interdependence. We have the parents or guardians also involved. And in this figure here, I say that we have the pediatric providers and adult providers. And if I were to redo this figure today, I would really focus on the team approach. So this includes physicians, so cardiologists, surgeons, nurses, NPs, PAs, psychologists, social workers, and other mental health care professionals. Depending on the health condition, it also may include occupational therapy, physical therapy, speech therapy. So we really want to think about a team approach when we want to improve transition outcomes. When we think about education in congenital heart disease, there's a lot of information that we wish to impart. We have medical information and lifestyle information. And on the left column here, the 2 things that I think are really important, if we could only choose 2, We want people to know the name and description of their cardiac condition. So if they're on a school skiing trip and if they break their leg and if they show up in the emergency, that they can tell the emergency team, this is the name of this is what I have. This is what you ought to know to take care of me. And we want them to know the importance of lifelong care. There are also lifestyle issues. So physical activity recommendations, education, career planning. I attended, it was a really good breakout session earlier on contraception and family planning. There's a lot of information. We also want to help them learn kind of a long list of self-management skills. We hope that they will be eventually able to speak independently with healthcare providers if they have the ability to do so, to make or participate in medical decisions, to contact health providers, to schedule and attend appointments, maintain their health records, adhere to medication. As a psychologist, I think it's really important that we help them learn how and when to access mental health services, know how and when to access emergency care, and also to understand health insurance matters. And we can do this. So here's a study from Andrew Mackey. We collaborated on this intervention, and we found that self-management and scores improved with 2 nurse-led one-on-one sessions. So during those sessions, the nurses provided individualized patient education. They created a health passport, so a portable health summary. They discussed 3 third-person scenarios. They had videos demonstrating poor and strong communication skills. We had a video about talking with your doctor, and we role-played 2 standardized healthcare scenarios. So 2 interventions made a difference. Sorry, intervention with 2 sessions made a difference. And I'd just like to acknowledge that we expect a lot from adolescents. And so although I'm targeting my presentation more to clinicians, I realize there may be some patients and families in the audience. And gosh, we expect a lot from our teens. This is a period of significant cognitive, emotional, and sexual development. Identity formation is a key feature. From a developmental perspective, there's often a sense of personal uniqueness. So I'm in love, and nobody has ever felt love like this before. There can be a sense of invulnerability. We know that adherence rates tend to be lowest amongst adolescents. And so it's very odd and difficult that the time that we often think about beginning transition is also the time when teens perceive lower vulnerability and are the least interested in talking about their healthcare. And this is another reason why we actually want to begin early. We want to begin in childhood. I love it when I see a 7 or 8-year-old who comes up to me and says, this is the name of my, my congenital heart disease, and I have a pacemaker. So it's great to begin early. And we know that relationships matter when we think about transition. And here was a survey of 257 US pediatric cardiologists, and they were asked about their perceived barriers to care. Number 1 was the parent emotional attachment to the pediatric provider. Number 2 is the patient emotional attachment to the pediatric provider. Down at the bottom were attachments to the institution. And I have worked with people in their 30s and 40s who are facing major health events and perhaps the end of their lives. And when they talk and when they think about what they want to have happen afterwards, they'll often say, I want people to donate to the pediatric hospital. So even though by that time they may have spent more time in adult care, there's this strong lifelong allegiance to the pediatric setting. And if you look at the 5th one down here, we see that there's provider attachment to the family and patient. And I think it's really important to acknowledge that many physicians and nurses have been taking care of patients for a decade or 2. So obviously, providers also get attached to patients and families. So for this reason, it's really important to openly address parental concerns. So fewer than half of parents think their child would be ready to take complete responsibility at age 18. I don't think they have to take complete responsibility. We want to help them to take as much as they can. It can be scary for many parents to let go. It's understandable. Parental over-involvement is understanding. So let's thank parents for their continued caring. This should not be something that we pathologize. And it's really important to fully explain the rationale for and risks and benefits of transition. Consistent messaging is essential. And this is where we come back to this team approach. So it's very confusing when patients and caregivers receive inconsistent messaging between providers within the same program or between outpatient and inpatient settings. So we want everybody to be sharing the same messages. We want to avoid deferring transition efforts to a single person. It's okay to identify as a transition coordinator, who's somebody who can kind of rally the troops. But what we don't want is a patient or parent says, I'm wondering about transition, and we say, go talk to that person about this. So this is something we want everybody to be versed in speaking about. It's important to present transition and transfer as natural and positive. So we want to avoid saying things like, I wish I could keep seeing you forever and I didn't have to send you to the adult program. And finally, making a public commitment can benefit patients, parents, and providers and staff. So we can hang signs. So when we talk about investing, signs are pretty inexpensive. You can hang signs that say things like, beginning in adolescence, we transition our patients to become more responsible for their healthcare. It is our standard practice to speak with teenagers on their own for part of every clinic visit. I think this is a really important practice, and we want to normalize it and prepare folks for this. And let's celebrate things. Our patients graduate to adult care when they turn 18 or 22 or whatever is typical in your clinic. So let's celebrate this. We celebrate when kids graduate from high school, or these days we even celebrate it when they graduate from kindergarten. Let's acknowledge this accomplishment. And here are some other strategies that you may wish to consider. So developing the educational checklist, preparing a written transition plan, provide clear expectations and a rationale for practice shifts ahead of time. Consider transition events for patients and families, just like you're doing today. And you may want to have that within your specific team. So when I was in Toronto, each year we used to have a transition event, a collaboration between Sick Kids and the program at Toronto General Hospital. Provide positive verbal reinforcement to patient and families anytime they engage in efforts that are directed toward patient education and self-management skills. So, give a high five when somebody comes in and they can tell you the name of their diagnosis. When you think about teamwork here, we can coach clinic booking staff to speak directly with patients as much as possible. I like the idea of incorporating a 2-visit approach to transfer in pediatric and adult settings. So in the pediatric setting, we don't want it to say to patients and families, okay, this is your last visit. We want to say, this is your next to last visit. So if the next time you come, let us know if there are any last questions that you have that you'd like to ask us. And even in adult care, let's not throw everything at them at once. Let's have the first visit more of a meet and greet, and then maybe getting to some clinical planning the second visit. Incorporate neurodevelopmental and psychosocial information into the transfer letter. Give a personalized transfer summary to all patients. And again, use language to celebrate transition of care. And as a psychologist, I just like to share a few language tips. So when we're providing education to patients or families, instead of saying, do you have any questions or concerns, which is a yes or no answer, say, what are your questions or concerns? Instead of saying, do you understand this information? Ask, am I explaining this clearly? When I talk to patients and families, it's not their job to listen better. It's my job to explain things well. When we think about language to convey compassion, and let's avoid saying, don't worry about this, because in the history of all time, when we say, don't worry about this, people don't automatically stop worrying. Consider things like, I understand this can be a scary or stressful situation. It's understandable it might take some time to adjust to a new team. I'm confident that you can do this. And language to convey empathy. Instead of saying, I know how you feel, say, I've heard from other patients and families that I can imagine this might seem stressful. Tell me what this is like for you. And I will say that anytime we're doing any transition efforts, let's share our work. So this is, by the way, is a website, iheartchange.org. that we initially developed in Toronto and now we made publicly available. So it really is for youth and young adults with congenital heart disease. There's a lot of information there and we wanted to make it available. So that's a website you can go to if you like. So we often use the bridge analogy when talking about transition, and I love that your transition event did this today. We talk about bridging the gap from pediatric to adult care. I just like to emphasize that on this transition pathway, there are many different types of bridges, and our goal really is to understand the starting and end points of each individual patient and support them on their journey. So in conclusion, it is time to shift expectations from transition as something that is nice to provide to invest in this essential component of care. We have this collective opportunity to help adolescents and young adults achieve the best possible outcomes and quality of life and to live as full and independent lives as possible for them. And finally, every member of the team, including clinicians, physicians, nurses, allied health, and administrative staff from pediatric and adult programs can collaborate and contribute to positive transition experiences and outcomes. And thank you very much. And I am going to stop sharing here. I can see you now. Well, I can't see anybody now. I can see me now.